So, what's in store for us today? Well, this is quite simple. We are going to understand the concept and efficient workflow of posterior restoration. And this is something that we do almost every day. And this is not new. This is very common. Okay, but we'll just go through it. All right. And secondly, we are going to understand the fiber reinforcement in a structurally compromised tooth. Okay, so most composites we know would offer perfect features for enamel replacement, such as higher wear resistance and even aesthetics. Okay, however, they are not able to equal dentine when it comes to resistance to fracture. Okay, so this issue is overcome by using dentine replacement material that is mainly fiber reinforced composite, like what Everex Flow would offer us. Okay, so this specific material would possess superior flexural strength and fracture toughness, and can also efficiently reinforce restorations because of its fiber content. Okay, so since this one is a fiber reinforced type of composite, it should be fully covered with a light cured composite to achieve a smooth and wear resistant surface. So we are going to learn more about this as we move along. Okay. So direct dental restorations, they have changed from amalgam to gold and a few resins that are used only for the interiors, and even to resins bursting into the marketplace are a lot. Okay. So now there are even more advanced or resins, like the newer class. We have the injectable, and with the goal of making resin restorations better, quicker, and even predictable. Okay, so in this webinar, I hope that I will get to discuss the history of why and how these materials are still evolving and the newest material available. Okay, so I hope that we get to learn the techniques on using this new bulk filled resins, and we get to discover through clinical cases that I'm going to share later on the potential pros and cons and why bulk fill resins will be necessary for the practice. Okay, so one of the few key points that I find important for us to understand is that we get to learn the advantages of bonded restorations over the traditional approaches in most clinical situations. We also want um, to know the optimal use of current restorative materials and systems. And we get to refresh our minds with preparation design, the principles of tooth preparation for bonded restorations. Okay. And lastly, dentine bonding protocol. Why is it important? Because we have to understand the rationale for immediate dentine sealing. Okay. Because as most dentists, including us ourselves, we spend a considerable part of our day placing composite restorations, and we cannot deny that. Okay, so during these appointments, we get to manage preparation designs, utilize matrix systems, dental adhesives, filling materials, and of course, finishing techniques. Okay, so we'll see to it that we get to improve predictability and aesthetics of this popular restoration for both anterior and posterior teeth. Okay, so there would be particular emphasis that would be placed on the newest materials and some tips and tricks on how we are going to improve efficiency. Okay, so here what you see are the common questions that we may have when we are confronted with a clinical case in our office. Okay, so we get to ask ourselves, how are we going to strengthen the tooth if it is too extensive? Do we even have to place a bevel for this? Is there a specific matrix system that I should use for this specific case? Is there a need for any desensitizing agent given that this is an extensive cavity? And of course, the question of what composite should you use? Okay, so in order to help us understand, today's restorative dentists need to really enhance their cosmetic skills in order to achieve growth and profitability in their practices. As a result of the latest nano microhybrid composite technology, dentists can now quickly, easily, and predictably treat posterior teeth, including, if we can include here, cervical abrasions, abfractions and things alike. Incisal wear, we get to restore it with, regain vertical dimension of the face. And together with that, provide strength and function beyond the patient's expectations. Okay? So there are a lot of improvements in composites, physical properties, the polymerization shrinkage, the reduction of internal stress and occlusive wear. They have made composite material a great aesthetic option as well. Okay? Reality is the rehabilitation of a heavily damaged molar, may it be because of an extensive caries, a fracture, repetitive restoration from the past, or even endodontically treated ones, they would all pose a challenge to clinicians. Okay, so what you see here, here's a fact. 80% of our daily work is posterior restorations. More and more patients would demand tooth-colored and minimally invasive treatment options. And indeed, it is important for us to increase our manual and verbal skills in this state-of-the-art adhesive, posterior concepts for direct, if we can also include semi-direct, and of course, indirect techniques in composites and ceramics. We cannot avoid, going into that path, because we also have entered the post-amalgam and post-full crown era. Okay, we would want to manage our clinical cases in minimally invasive procedures, MID, minimally invasive dentistry. Okay, and also, a patient would come into you and it is actually not a brand new cavity. Okay? It is mostly, a case for replacement, and many reasons would come through for this replacement. I think the top would be marginal defect, having leakage. There's formation of secondary caries. There's fracture of the old restoration, and worse, there's fracture of the tooth or the adjacent tooth to it, or just simply the patient would ask you to replace it because of an unacceptable appearance. Okay, and that is actually what this article would share us. That there is large MOD restorations, and we are in the verge of really considering if we are going to do an indirect restoration in the form of an inlay, or we can work with it with using a short fiber reinforced direct restorations, just like what Dr. Pascal Magne is advocating, biomimetic dentistry. Okay, and when we talk about posterior restoration, it is not just about the caries activity per se. Okay, it would also involve endodontically treated teeth, like what I have mentioned earlier. Okay, so if you have encountered a case like this, similar to this, the reconstruction of structurally compromised restoration, or structurally compromised posterior teeth rather, is really a challenging procedure. Okay, so the tendency of endodontically treated teeth to fracture is considerably higher than the vital teeth, of course. Okay, we always want to remind our patients that if they are not choosing crown placement after an endotherapy, the tooth is more brittle as compared to the other natural teeth, to a vital tooth. Okay, so although in so many years, posts and core buildups followed by conventional crowns have generally been employed for the purpose of reconstruction, because that's what we consider to be, a strong and reliable final restoration for these situations. Okay, so but this procedure would entail sacrificing a considerable amount of residual sound enamel and dentine because of the tooth preparation itself. Okay, so researchers has drawn attention to this fiber reinforcement because, as you see, fiber reinforced composite is basically designed to replace dentine. Okay, it enables biomimetic restoration of the teeth. Besides improving the strength of the restoration, the incorporation of glass fiber itself into the composite resin would lead to favorable fracture patterns. We are not saying that we totally eliminate fracture, that it's never going to happen again, okay? But we get to lead it to a favorable fracture pattern because the fiber layer acts as a stress breaker and it would help to stop crack propagation. Okay, so we will further understand this concept as we go along. So hang on and just stay with me as I go about this webinar. Okay, so you would see here in the screens, in your screens right now, that there's this case of a molar that would exhibit extensive destruction of the coronal tooth structure. Okay? You would see in the radiograph on the right side of the screen is a radiograph, a preoperative radiograph that would reveal a periapical radiolucency. It's a radiolucent lesion in the region of the mesial and the distal root of tooth number 4-6. Okay, so clearly you would also see that there is this, there's a compromised periradicular dentine at the coronal third of the mesial root due to a poor endodontic access activity. Okay, so it's this situations are very common. The patient would come into you with an existing, an ongoing root canal therapy or endodontic therapy that has been accessed for quite some time. You know what I mean. They would not come back for treatment, and then they would seek for another dentist to work on the case just because there's a fracture, the temporary filling has been removed, and all sorts. Okay, so we have to understand that at this point, the successful restoration of endodontically treated teeth would require coronal seal, protection of the remaining tooth structure in order for us to restore the function and for it to have acceptable aesthetics. So in situations like this, the use of custom-made or even prefabricated posts has gained popularity and is now frequently employed for the reconstruction of these areas. I have been using this method for quite some time, especially in the early years of my practice. Okay? However, one mode of failure of post-restored teeth is root fracture. Okay? So this would underscore the need for minimally invasive procedures. Okay? Therefore, intracoronal strengthening of teeth to protect them against fracture is very important. Okay, so particularly in areas, posterior teeth where the stresses would be generated by forces of occlusion, when the mouth is in function, when it is masticating, this can lead to the fracture of the unprotected cusps. Okay, so more importantly, the amount of remaining tooth structure following endotherapy is an important factor in the evaluation of a tooth's prognosis regarding restorative options, regardless, again, if we are going to proceed with a tooth filling or we are going to proceed with a crown fabrication, a form of prosthesis. Okay, so this is an example of a case that we do not actually want to see in our office. That there's an existing ongoing endodontic therapy on tooth number 1-4, and then on tooth number 2-5, you would see the orifice was already sealed, but there's a huge problem here when it comes to fracture. Okay, so we have to know how to approach these situations right here. Okay, and there are growing advances in adhesive techniques over the past few decades. Conservative restoration of endotreated teeth is really a reasonable choice. Bonded coronal restorations are preferred over the more radical full crown preparations to prevent further loss of healthy tissues, as adhesions would ensure sufficient material retention, and it would also eliminate the need for aggressive macro-retentive feature. With that, we get to do more economical and time-saving options as well. Okay, so by incorporating or reinforcing short fibers in two composite resins, we can solve many problems, related to the restoration of badly broken down teeth. So we basically understand that endo-treated tooth would have special needs, and it would far exceed the requirement of a vital teeth, of course. Okay, although restorations that involve metal and let's say conventional porcelain fused to metal crown supported by a radical an apical custom made or prefabricated post, may it either be a dowel post or like the one you see on screen, like a fiber post right here. It remains to be widespread. It is very well known. Okay, but then again, their invasiveness in the root as well as in the crown has been extensively criticized, with the consensus slowly shifting towards minimally invasive dentistry techniques. Okay, so there are a lot of um, factors that we have to consider when we are going about restorations of this extensive cases, this clinical situation. So regardless of how badly broken it is or how much the case is challenging us, it is best that we understand that there are a number of factors that would influence the success of restoration. And I have summarized them into three. Okay. So first is the patient factor. Okay. So something that is beyond our control. Okay. So this is basically dependent on what is presented to us. Okay. So we can consider caries risk as a patient factor. Of course, we have no control over it. The age of the patient, oral habits of the patient, oral hygiene, and even diet modifications chosen by the patient herself or himself. Okay. We can also include the type of the tooth, the anatomy, the tooth's position in the dental arch, the design and the size of an existing restoration, if there is, and the number of restored surfaces. Okay, so this is something that you would just see when as soon as the patient would open their mouth. Okay, next is the clinician's skill. Okay, so this is basically our judgment, the materials that we are going to choose, and the approach that we are going to do in managing the case. Okay, and this is directly correlated to the third factor, which is the restorative material, the material that we are basically going to choose for this specific case. Okay, there is no blanket solution for every case that we are going to encounter in the office. There would be different situations, and different materials would arise from that. Okay, so with this, we must know how to maximize the potential of the materials that we are going to use to have a more predictable outcomes in the end. Okay, so I kept on mentioning predictability. Okay, so how are we going to make these posterior restorations more predictable? Okay, of course, we would want to consider simplified placement of the material and no sensitivity, post-operative sensitivity at the end of the treatment or at the end of the restoration. So how are we going to decide which material to use? Okay, so it has been our practice that adhesive bonded resin materials would be our go-to material of choice for most of our cases. Okay, excuse me. Therefore, the application of modern evidence-based approaches may result in more effective composite resin restorations. Okay, so the key here is getting it right. Okay, so we have this three factors or considerations in order for us to get it right, to have a successful restoration, to have a good prognosis. Okay, we have to have the right environment, right choice of material, and the right technique. All right, so let's just go over them one by one. Okay, so with right environment, we are talking about the area of where we are working it on. It would involve isolation. Okay, so as you can see, Bonding of composite resin to contaminated human enamel and dentine would cause degradation. Okay, so simply contaminated area would degrade the restoration. It depends on how much moisture you get in there, and that's how much degradation would happen. You know, it can range from 20% to even 100% degradation. It's as if it's going to be useless. You are now going to re-etch, you know, and have to do the process all over again. Okay, so there are many ways, of course, in order for us to achieve this great isolation. So gold standard will always be rubber dam isolation, you know, rubber dam assembly, the placement of it. Others would use isolite, the ones with a bite block, there's light in it, and then a retractor. And then you have the suction tip connected to it. Okay, and then of course, if um, the situation does not permit, you know, rubber dam assembly and things like that, we can place cotton rolls with holders, you know, cotton triangular pads. You know, there are a lot of options in order for us to help us make the environment moisture free. Okay, so generally what we would want to work on is an environment that has no moisture, you know, in the procedural area. There's no moisture to the throat as well. We don't want to cause any discomfort to our patient. Proper retraction of the tongue. That's why nowadays we are really into doing four-handed dentistry, so that we would have our dental assistant to be helping us with the retraction, with elimination of the saliva inside on the floor of the mouth, you know, and things like this. And it's also best if we get to have bite block, you know, the help of a bite block for us to achieve good mouth opening. And then, you know, illumination and proper brightness levels during working would be appreciated as well. And lastly, of course, we do not want to have any breaks or interruptions as soon as we start doing our restorations. Okay, so we would want to make our patients as comfortable as possible. Okay, so in another article that I have read, this was published in 2010, I found this interesting because it says that when the tooth is exposed to saliva, there is the presence of structural defects present in the interface of the tooth tissue. So that would indicate the necessity of providing proper isolation during this procedure. Okay, so the right environment does not only focus on isolation itself, but also the proper placement of a matrix assembly. Okay, so the ever popular Toffelmeier matrix system would never be out of the picture. Okay, and I assume that you would still vividly remember the horror of placing this assembly into the patient for the very first time in your life. Okay, or even during your practical examination, probably in the dental school. Okay, but nowadays we are leaning towards the use of a more effective, you know, way in order for us to restore the proximal areas, and this is with the use of a sectional matrix system. Okay, it can be a sectional matrix system, just like what you see on your screens right now, or a retainerless matrix system. You know, we have a lot of options. What's important here is that we understand that we get to have this pre-contoured matrix band, okay, wherein there's no need for us to burnish, for us to achieve this proper contact during condensation or during the increment of the material. Okay, of course, placement of wedge would still be necessary. Okay, but with pre-contoured matrix band like this, okay, you would see that you get to have that proper contour, that you get to seal the interproximal contacts. Okay, because a contoured proximal contact would lead to the highest fracture resistance of class 2 composite resin restorations when it is loaded vertically on the marginal ridge in a direction parallel to the long axis of the tooth. Okay, so nowadays studies are really up to about the edge of using a sectional matrix rather than the old conventional type or the Toffelmeier, because as you see, the use of Toffelmeier, we often get a flat proximal surface right here. There's no contour, okay? Whereas if we are going to use a sectional matrix, the loading of the proximal contact that is parallel, okay, to the long axis of the tooth, okay, and we get this 1 millimeter support inside the marginal ridge, okay. Therefore, this would create stronger contoured proximal contacts, okay, since again they are pre-contoured, okay. So there is several advantages that we are going to get if we are going to use this pre-contoured or this anatomical matrix system, as others would call it, okay. And to one of the contributing factors here is the way that the cavity prep is done, and it is an important factor that we have to keep in mind, okay. So the proper usage of effective matrix system will keep the restoration longer, okay. You would want to achieve contour because basically it would mimic natural teeth, okay? So we don't want to have possible food traps in gaps like this, okay? We don't want to have overhang like this one, that as seen on this radiograph, because in the end, this would cause irritation to the gingiva. This would cause trauma to the area or to the tooth, and we don't want to end up extracting the tooth and discovering that there's this huge overhang of this material right here, okay. So there are a lot of materials that we can use. We have the Triodent, we have Torvium, we have Polydentia, we have Garrison. We have a lot of options to choose from in order for us to achieve this part right here, okay. So moving on, the next factor is getting the right choice of material, okay? So again, we go back to the question, we go back to the case. What material are we going to choose after the completion of the root canal therapy of this case, okay? So here's a list of criteria that we can use to decide, okay? So first, there's a need for us to satisfy the patient's aesthetic requirements, okay? Next is for us to know that there's a need for a strong and durable restoration that lasts. Of course, this is understandable, okay? Third is the need for a versatile material that can be used for different clinical situations. We don't want to have a material that would be sitting long in our drawers in the dental office, and they would be just drawn out from the drawer, once or twice a year because it's just specifically for a rare case like this. We would want a material that we can apply for most of our clinical situations, clinical cases that we encounter, okay. Next is the need for minimum intervention dentistry, okay, and to find a compatible composite to work with it. And then lastly, the need for a restorative procedure that is fast, easy. And again, I would mention it, something that would, a material that would yield predictable results. We don't want to be guessing the outcomes of the restoration that we are going to provide our patients, because often patients would ask, doctor, how long will this last? How will this treatment option help me with the daily function and things like that? So for this one, we would want it to be predictable. We know how it would end up, okay? So if at this point, we are going to look for a solution to prevent cracks in restoration and teeth, okay? So if we encounter cases like this, large cavities, missing cusp, an old amalgam restoration, and an endodontically treated tooth, is composite still the right choice? Okay, because we have to know that once a tooth is cracked, it becomes difficult to repair and reinforce the remaining tooth structure. Okay, there's always the risk of cusp fracture that would lead to little residual tooth structure to bond to, and limited longevity of the tooth in the arch. Thereby, we are now limiting, or we are cutting short the lifespan of the tooth inside the mouth. Okay, and another thing is that there's this risk of fracture under the gingival line. Okay, and if this happens, we are left with no choice but just to extract the tooth, and we have just cut short the lifespan of the tooth. Okay, so there's a need for stronger composites, obviously, because we recognize that posterior composite restorations fail typically as a result of leakage. And that is because, the tooth lost its seal. Okay. However, as the size of posterior composite increases, the likelihood of failure due to the fracture also increases. Okay, so they are correlated to each other. Okay, so large composite restorations, they do not survive as well as large amalgam restorations because they are more prone to fracture. Okay, and according to this article, to this study, to this literature, by Van Dicken in 2011, the most common reason for failure of the composite, okay, composite restoration or fillings, it is because of the fracture of the material itself, followed by secondary caries. Okay, 7 years of 7 years of study was 14.9%, and nearly 50% of them were composite fractures. Okay, so in general, it's best that we get to understand that fracture often happens as a result of tens of thousands of repetitive bites. It happens from the surface of the conventional composite material, and it would slowly propagate through the filling. Okay, if one of the potentially hundreds or thousands of micro cracks is really able to penetrate deep enough, and the material would suddenly give up, and fractures would catastrophically under a fairly low stress compared to the maximum bending stress. Okay, I'm quite sure that you have encountered a patient, that would tell you that, doctor, I was just eating soup, I was just eating bread, I was just eating a very soft food, and yet this tooth fractured. How did that happen? I did not bite on anything hard. Okay, so it's best that we get to explain to them that it did not just happen right at that moment. There has been a fracture line, and it has been because of the thousands of repetitive bites, and it's fractures of restorations and teeth are very frequent. Okay, and fractures are really a huge problem. So just take a look at this case right here. So the tooth is fractured. There's a need for an endodontic therapy, but the endodontist required crown lengthening by a periodontist. And so it has been performed prior to any fabrication of restoration, even the endotherapy. Okay, so in another study, there's a study that shown the fracture was the main cause of restoration replacement. Okay, so according to it, the data would show that adults, the longevity of restorations valid from 6.4 to about 7.3 years. Okay, in 2007, 34% of the restorations were made due to primary caries, and 22% was due to secondary caries, and the remainder 31% was due to the fracture or loosening of the restoration. Okay, so we are clearly seeing that it's not always going to be a new cavity, and it's not always going to be an endodontic procedure. So a huge chunk would also be coming from fracture or a loose restoration, existing restoration. So with this, we would want to consider fiber. Okay, so there is variety of reasons as to why we are going to choose fibers as an alternative to large amalgam restorations. Okay, we would want to cut the cycle in the repeat restoration cycle. You know, there's a cavity, you restore it, and then there's recurrence, there's endodontic therapy, and then you restore it again, and then there's fracture, there's reinfection. You know, the cycle just keeps on going. We would want to end that cycle and make sure that we get to extend the lifespan of the tooth. Okay, so some patients would also need um, restorative options that are tuned to their financial situations. So let's say the patient is not yet ready for a crown fabrication, as we obviously know that this would require more cost, you know, and more time in the fabrication, multiple visits. Okay, we would also want to use fibers in restorations following endodontic treatment. Okay, because you see, endo treated teeth without dentine support are more prone to fracture. And if we can just strengthen them, then this is an important point. Okay, because I have mentioned that endodontically treated tooth are more brittle, not compared to vital teeth. Okay, we would also want to do tooth conservation where large bonded restoration is desirable. And lastly, transitional restorations as part of a rehabilitation. Okay, so we would want to choose fibers again because basically it would resemble the tooth. Okay, with enamel, it would have same higher fracture toughness. Okay, fibers in dentine would give it much higher fracture toughness, and in enamel, predominantly it is abundant with crystalline and it is densely packed with crystals, you know, and it would give higher strength and surface hardness. So this is just a very simple explanation why we see many cracks in our teeth, but they do not progress all the way through and they just stop at the DEJ. Okay, so we are introducing the fiber reinforced composite. Okay, and this is where we would want to make this as our popular choice for this matter, for this clinical challenge. Okay, so the FRC, no, fiber reinforced composite, would form a network inside the composite to make the material stronger. Okay, so this is if we are going to compare, this is the same principle as with the iron rebar that is used in construction. That's why, you know, you would see pages that would tell us that dentists are not only doctors, we are also artists and engineers, you know. So this material, this fiber reinforced composite, this is in the form of either the old EverX posterior and the new EverX flow. This would basically be used together with composites as a sandwich structure. And the bond strength between the base and the material and the overlying composite is an important important factor rather. So in most cases, the EverX flow that would act as a base, and there's this composite bond, okay, on top of it, there's higher bond than corresponding composite to composite bonding. Okay, so the high bond strength leads to this reliable sandwich structures. Okay, so this is also due to not only a high chemical bond strength, but also the micromechanical retention created by these fibers that you see on your screens right now, okay, at the interface of the material. Okay, so excuse me, these fibers, you know, this would help design this is basically designed to help preventing fractures and to help arresting crack propagation within fillings to avoid catastrophic failures. And this is based on Professor Valitu's researches. If you have read some of his journals, you know, it is based on his researches and studies when it comes to the restoration of endodontically treated molars. Okay, so we would want to see that EverX flow or posterior significantly reinforces composite crowns in endodontic treated molars, resulting in easier to restore fractures. So what you see is this fiber reinforced flowable composite is best for core strength. Okay? So EverX Flow is a short fiber reinforced flowable composite indicated for dentine replacement. This can be placed as a bulk fill or a bulk filling material and can be used as a core build-up applications, or in cases wherein there's weakened or there's cracked tooth structure together with a conventional composite as the enamel layer. Okay, so this would reinforce the restoration. This would display an exceptionally high fracture toughness, and as mentioned earlier, fibers has the capability to redirect cracks and avoid catastrophic failures, which makes this material an optimal material to use in weakened or cracked teeth. For instance, removed amalgam, old amalgam restoration that has been removed. This can also be used for MODs, endodontically treated teeth, And with this material, it has this viscosity that would allow us to flow and at the same time be able to adapt perfectly to the cavity floor without slumping, without flowing, and even this can be utilized in maxillary molars. Okay, so this optimal consistency would make this as our restorative treatment option, and it would make the situation, the process faster and easier. Okay, so what is extraordinary with this material is that it has these two shades right here. You have the bulk shade, okay, and it is more translucent. Okay, therefore we get to increment this up to a maximum of 5.5 millimeters, and you get to cure it from top to bottom. Okay, so this is optimal for deep posterior cavities and for a faster placement. And then we have here the dentine shade, okay, which is more opaque in a way that it mimics a dentine color. So you get to apply a maximum of 2 millimeters, and you get to cure it, polymerize it from top to bottom. And this is optimal for more aesthetic results and for core buildup. Okay, and okay. So we are now on to the last factor, okay, wherein it is important for us to get the right technique. Okay, so we know now which material to use, and this is the point wherein we have to learn how we are going to apply this onto the tooth. Okay, how we are going to apply this to our case. So let us begin by including adhesive. Okay, since this is a fiber reinforced composite and basically we are still going to use a conventional composite, it is best to pair it with an adhesive. Okay, an adhesive that can display a faster dissolution of the smear layer and would have improved infiltration as soon as you apply it onto the dentine. Okay, so this is showcased in the G Premio bond. Okay, so I hope you're quite familiar with this one. So this would enable this bonding agent to achieve sufficient bond strength to both enamel and dentine, even with a very short application time, regardless of the etching mode. Okay, so this would also display an excellent bond strength, not only to the enamel and dentine, the tooth structure, but also to indirect substrates. Okay, so there's this unique composition that is based on these three functional monomers, the Formet, the MDP, and MDTP, which enables stable bond, again, not only for the tooth structure, but also to composites, metals, including precious metals, zirconia, and alumina. Okay, so you would have ample working time with this G Premium bond, which is about 7 minutes from the dispensing time, and it is it is actually matte and frosty when you apply it to the surface, and it would also aid in composite manipulation and adhesion. So in most of our restoration cases, we would want to have a bonding agent would have the thinnest film thickness. So this one would only yield 3 microns of film thickness, which makes it unnoticeable as soon as you apply it onto the surface. Okay, so this, since it becomes infiltrated in the surface quite fast, we are not going to experience post-operative sensitivity, as this can also act as a desensitizer because it seals off the dentinal tubules. Okay, so this one is also hemo-free, then therefore there is no degradation over time because there is no uptake of the water inside the cavity. Okay, so now that we have the adhesive, let us now just go on step by step on how we are going to apply or utilize the fiber reinforced composite material. Okay, so going back to this case, so again, this is the case shared by Dr. Suarez, wherein this is a case of a 25-year-old female patient presented with the chief complaint of pain in the region of the mandibular right first molar. Okay, so this one is on the tooth number 4-6. Okay, upon clinical examination, extensive destruction of the coronal tooth structure was noted. And by this, a radiographic analysis was necessary to further evaluate the tooth, of course. Okay, so the radiograph revealed a periapical radiolucent lesion around the mesial and distal root of tooth number 4-6, and the periradicular dentine at the coronal third of the mesial root was compromised as a result of the poor endodontic axis activity. Okay, so obviously the tooth required endodontic therapy, cleaning and shaping of the canals, calcium hydroxide medicament for over a month, the works. Once the tooth demonstrated signs of radiographic healing of the periapical lesion and the absence of symptoms, the obturation was completed with cold lateral condensation and resin-based sealer. Okay, and now we are proceeding to the real deal of the case. Okay, so in order to reinforce the remaining tooth structure and avoid any aggressive prosthetic procedures, the tooth is perfect. It is a perfect candidate for a fiber reinforced composite restoration. Okay, specifically, what Dr. Suarez used in here is the EverX posterior. Okay, so in this, this is the left radiograph is the 6-month follow-up, and the one on the right is the 1-year follow-up showing appreciable healing in the periapical area. Okay, so other cases that I have encountered and managed in the office myself is this case wherein the tooth underwent internal whitening procedure, internal bleaching. Okay, the tooth is previously endodontically treated for, I think, if I can remember it right, this was about 2 or 3 years back. Okay, and the tooth is discolored, and the patient is still not ready for any crown fabrication, and so we would just want to address the discoloration. That's why an internal bleaching procedure was performed on tooth number 1-4. Okay, and right after it, the tooth is going to be sealed again, and it is reinforced with EverX Flow as a dentine replacement. And then composite restoration is done using Genial Universal Injectable. Okay, so there are a few of other cases that I would want to share, and this would just mainly prove that with this material, it is fairly new. But then again, EverX, or generally fiber reinforced composites, is a heavily backed up material with studies. Okay, and it has been proven, it has been used, and there are a lot of evidence-based studies revolving around it. Okay, so this is a case by Dr. Benjamin from Germany, and this is basically an old composite restoration, a fracture on one portion of the cusp, and replacement of this is necessary. Okay, so after the complete removal of the old restoration, the walls were built with genial universal injectable, and then the placement of the EverX flow right at the center to reinforce the tooth. And it is fully covered now with composite as a final restoration. Okay, so this is how it looks like post-operative. Okay, so we were actually really able to see the anatomy was restored and the tooth is now going to be functional, and the patient can use it with ease knowing that it is reinforced right at the center of the tooth. Okay, here's another case shared by Dr. Dahan from France. This one is another case of an endodontic procedure, okay, with a resin based sealer so that we get to layer it immediately with resin material, because if not, if we are using the conventional zinc oxide eugenol, the slow set ones, then we still have to seal this portion with a glass ionomer material before we get to apply the fiber reinforced core material. Okay, so the walls were repaired, placement of the fiber reinforced material right at the center, and then sealing off with composite over the top. Okay, here's another case by Dr. Tapia from Spain, an old amalgam restoration, and there's an existing there's caries progression also at the adjacent tooth. Okay, so it was restored. The old restoration was removed, and this was restored using reinforced with EverX flow, the fiber reinforced composite, and restored with composite over the top, making the tooth functional once again. Okay, so hold on to this. Okay, so let me just share. This one is quite different. This is a radiographic image of, this is from Professor Sabag from Lebanon. So you would see that apart from the clinical presentations, we would have here a radiograph, and you would clearly see that the combination of the EverX flow and a genial composite would also be highly visible to radiographs. So you would not have a hard time if you are a dentist, attending to the patient, and the previous dentist used this materials right here, then you would be properly guided as to there is a material that is very opaque and visible to the radiograph. Okay, and lastly, I have another slide that I would want to share here. This is a case. This is obturated. A freehand cusp by cusp build-up technique was utilized. Okay, there's a great advantage of building the anatomy cusp by cusp because you get to use one syringe of composite. The anatomy is already created before finishing, and this would enable to save valuable time during the last steps of the procedure. Okay, so as you can see, I performed selective etching onto the cavosurface margin of the tooth, of course with bevel. The margin is beveled. Application of G Premio bond or the adhesive both on the enamel and the dentine level. Placement of the short fiber reinforced material. So this one is in the form of the EverX. And then the cusp by cusp build up with an injectable composite right here. Okay. And right after we get to mold it, I was using a brush with with a stick resin. Okay. And this is the final outcome. Okay. So this was already checked with premature contact. Any premature contact was removed so that the patient can use this without any worries or any possibilities for trauma from occlusion. Okay, so I hope that I was able to share clinical situations on how we get to apply this in our office. And what you get here basically is superior results if we use this material for flexural strength and fracture toughness. Okay, bottom line is that fiber reinforcement in dentistry is gradually gaining momentum and is being used for various purposes, such as fiber reinforced bridge. We can use it, we can utilize it for periodontal splints, orthodontic retainers, FRC, resins, and even posts, like what I have shown. So to better understand the concept, the incorporation of this silynated e-glass fibers in the composite matrix would result in an FRC material that provides fracture toughness greater than dentine and almost double that of conventional composites. Okay, so the mechanical advantages provided by FRCs are flexural strength, fatigue strength, elastic modulus, and bond strength. Okay, so we are by now convinced that this can really help us a lot in most of our posterior scenarios, posterior tooth scenarios. Okay, it has this stress-bearing component and by arresting crack propagation or crack deflection. Okay, so fibers can truly help avoid catastrophic failures. Thus, the fracture pattern under load is changed, resulting in this favorable mode of failure that is easily restorable, and the teeth concerned may be eliminated in clinical service without any additional treatment. Okay, so again, let me clarify, it does not mean that fractures would never happen again, okay? But if it does happen, it is led to an area wherein we get to restore it easily, okay? And so this is the end of this lecture. Thank you very much for your time. If you have questions, I think we do have our Q&A portion, or else you can send an email through this address right here. So thank you very much again.